Hey there, I'm Drew. I'm one of the internal medicine residents. I'm going to be talking with you about heart failure and its bedside diagnosis. I used a couple resources, mainly Mangione, second edition, and McGee, third edition, and the duration of the presentation is going to be about 10 minutes and 19 slides. It will tie into the entire bedside diagnosis of heart failure course. We'll be going through 7 different items and focus on each of these throughout the talk. The point of each section will be to introduce the method and very little behind physiology or evidence, but maybe a few pearls. We'll start with everyone's favorite, pulsus alternans. So pulsus alternans. This is a finding of alternating intensity beats on palpation of a distal radial pulse. That's the first pearl. You're feeling distally. The distal pulses have higher sensitivity for this finding than brachial, carotid, or femoral. So try and use a radial pulse. It's everybody's favorite, so not a difficult piece of advice. The second pearl is that you're feeling very lightly. It increases the sensitivity of the finding. It's a very subtle finding at its baseline. And a way to also try and bring this out would be to use a cuff. It's not as convenient as just feeling after you shake somebody's hand, but inflating the cuff above the first set of court cough sounds will only allow that more prominent amplitude to transmit through, so you'll be hearing court cough sounds at half the heart rate of what you're hearing over the apex. Next is Valsalva response, which is kind of the physical exam nerd's dream for heart failure, but also very useful. The method of Valsalva response is setup intensive. First part is patient education. You tell the patient to Valsalva for 10 seconds and then breathe normally for 30 seconds after that. While they're doing that, you have a blood pressure cuff inflated to 10 millimeters of mercury above the systolic blood pressure or first court cough sounds, and you're listening with the bell of your stethoscope at the brachial artery for when court cough sounds happen throughout this cycle of Valsalva and then normal breathing. What is the normal Valsalva response? The normal is to hear court cough sounds twice during this cycle, at phase 1 and phase 4, the first and last. I'll let you read about what the physiology represents behind those 2 times and the phase 2 and 3 in between. The abnormal Valsalva response. I want to emphasize a couple things here. The first thing is just what is it? It is absent phase 4 overshoot or the square wave response. Absent phase 4 overshoot is a lack of court cough sounds at the end of this test. The square wave response is just persistence of court cough sounds from phase 1 into phase 2. The second thing I want to emphasize is that this is a powerful finding, has an LR positive around 7 and an LR negative around 0.1 for abnormal left heart filling pressures and reduced ejection fraction if it's positive or if it's present or absent. Next in line, jugular venous pulse, arguably the most challenging but rewarding skill of a physical exam Jedi. How do you determine the jugular venous pressure? I won't go through this sequence step by step. You can read it. I wanted to emphasize a couple of things. The first thing is, notoriously, physicians underdiagnose abnormally elevated jugular venous pressure for a variety of reasons. One of those reasons is that the commonly held belief that the mid-right atrium lies 5 centimeters below the angle of Louis is actually an incorrect assumption. That distance can change drastically depending on the angle of the torso, and there was a study actually showing that correlating with CT of the chest that it angles above 45 degrees. The distance between the mid-right atrium and the angle of Louis can vary between 5 and 9 centimeters. So if you use 5 centimeters added to your JVP to estimate the central venous pressure for every angle, you are probably systematically underestimating by about 4 centimeters, 4 to 5 centimeters. The second thing I wanted to emphasize is documentation of jugular venous pulse, and that is that avoid no JVD in your documentation. If you don't see the jugular venous pulse, then just say JVP not visualized. That's a much clearer way to convey this to others.
The jugular pulse consists essentially of 4 main waves: A, X, V, and Y. A and V being crests, registering high pressure, X and Y being troughs or periods of low pressure. The A wave corresponds to right atrial systole. A fifth positive wave, C, may interrupt the X descent. The X descent begins with atrial relaxation and is augmented during the earlier part of ventricular systole by displacement of the floor of the atrioventricular septum towards the apex of the heart, creating a negative pressure within the atria. The venous pressure rises later during ventricular systole to form the V wave, because at this time outflow from the atria is temporarily obstructed. The Y descent, or the downslope of V, begins as soon as the tricuspid valve opens, when right atrial and ventricular pressures equalize rapidly and fall together to the trough Y, after which they rise again before the onset of the next atrial contraction. It must be emphasized that accurate analysis of the waveform of the jugular pulse and reasonably precise measurement of the amplitude of each individual wave is usually possible at the bedside. The patient should be placed supine if the pressure is below sternal angle level, or propped up if the pressure is raised, the correct position being that which favors maximum jugular pulsation. There are 2 main waves: the A wave of atrial systole, the V wave of ventricular systole, and 2 troughs, X and Y, per cardiac cycle. The movement is soft, diffuse, undulant, and normally impalpable. When timed against the carotid pulse, only the first trough X appears to coincide with systole. The A wave precedes it, the V peak is appreciably later, and Y is clearly diastolic. You can see the arterial pulse here clearly by the light reflection on the red spot. The venous pressure rises on expiration and falls with inspiration, passively following the changes in intrathoracic pressure. The amplitude of all the waves increases during inspiration. Sir Thomas Lewis pointed out that the most satisfactory reference point from which to measure the venous pressure was the sternal angle, because this was about 5 centimeters above the center of the right atrium in both horizontal and vertical positions. With reference to the sternal angle, the venous pressure swings around a mean level of about -2 centimeters in the horizontal position, but the range is considerable. Indeed, in this normal subject, the maximum systolic level, which happens to be A, is plus 3.5 centimeters.
And this is a table just to help you identify the different ways that venous pulse and arterial pulse are different, and they are quite different. Abdominojugular test is next, or as some might know it, hepatojugular reflex, hepatojugular test, multiple different names. I'll let you read above about the method of the abdominojugular test, but there are 3 common mistakes associated with it. The first is calling it hepatojugular reflux, or worse yet, hepatojugular reflex. This is an archaic term for abdominojugular test. You do not have to press only in the right upper quadrant to elicit this. You can press anywhere on the belly to put pressure directly on the splanchnic vasculature. And that's actually the second common mistake associated with this, is that thinking pressure must occur in the right upper quadrant. The third is the inadequate duration of pressure. Many studies have looked at this, and the optimum duration is about 10 seconds. More than that doesn't really change the finding significance, and less can decrease sensitivity and specificity. This is a somewhat poor example of positive abdominojugular test. We identified the spot, applied some pressure, and it's much higher now. Relieve pressure, and it resumes its prior spot. S3 is next, another toughie. I wanted to emphasize two things with S3, one about the finding itself, and two about the evidence. Number one, if you really want to elicit S3, you got to get the patient in left lateral decubitus. You got to listen with the bell over the apex. And usually you're hearing this in mid-diastole, early to mid-diastole. It's not something that occurs just after S2. The second thing is the evidence. This is a very powerful finding, and if it's present, there's a positive likelihood ratio of 4 to 5 for elevated left heart filling pressures and reduced ejection fraction. Finally, crackles and lower extremity edema combined. Two things to emphasize for crackles and one thing for lower extremity edema. For crackles, number one, please use the term crackles as opposed to rales. There have been multiple major societies that have recommended against use of rales because of its archaic use and just lack of clarity. Number two with crackles is that this is a limited finding. The significance of it is limited. Probably not because of any underlying lack of power in the finding, more so because of a lack of agreement between practitioners who listen to the same chest. The kappa statistic associated with is about 0.21, which is consistent with only slight agreement. For lower extremity edema, I just wanted to emphasize that there's a long differential for edema in the legs. Only in conjunction with abnormally elevated JVP is lower extremity edema consistent with cardiogenic edema. And that's the end of the talk. Thanks for listening.